Oh, good afternoon. So it's so nice everyone came out to share a little bit of their Saturday with me, so with us. So thank you for doing that. And just kind of a little bit of housekeeping things first is just this talk is not really a talk. It's more just sort of little snippets of things that we've learned over the years. So there's not really a true like sort of cohesive agenda here other than to kind of tell you about some of the things that we've learned through a brain bank. And I always start when I do these types of talks about the brain bank is like, why do you even need a brain bank? And the main reason is all of these conditions, all these movement disorders, we don't have real animal models for them. We don't have ways, animals don't get Parkinson's disease, they don't get essential tremor. And so we have to study the conditions in human beings. And so this brain bank program, which we're so fortunate to be so close to here, one of the kind of world recognized brain and body donation programs in the world. And so it's so nice that it's kind of almost in our backyard here and living in Sun City, Arizona. So I'm going to just give you a little bit of an overview. Let me see if I can, where is this? All right, how do I go forward? There we go. Okay, I just had to push harder, I think. All right, so how I have this done is a snippet of a publication that we did with the authors, and then the titles in yellow with the date, so you can kind of see that that's not so important, but just to know that it was a publication, and then a couple of bullet points of kind of pointers of things to learn. So the first thing is just this description. We actually published an overall overview or description of what the Brain Bank program is. So what is it? It is a annual assessment in person. So it's an aging study. So people come annually, once a year for evaluation. They get a movement exam where a movement disorder neurologist assesses them. They get a cognitive evaluation, so getting their memory tested, their language ability, et cetera. So we do a sense of smell testing, and you'll learn more about this as we go, but it's called the Unified University of Pennsylvania Smell Identification Test. So it's this little scratch and sniff smell test. So we do questionnaires about everybody's bodily functions. So we do sleep questionnaires, and then we do sometimes some spinal fluid and skin biopsies, depending on some of the studies that are kind of going along with it. So that's an overview of the program. So, and then of course, when you're done with your brain, you to science. And so that's what most of what we're going to be focusing on. So we doing okay? Yeah, okay. All right, so that's the overview of the program. And then most of what I'm going to be talking about are people who have already contributed their bodies to science. So they've passed away, and this is data then on autopsied individuals. So this program has been going on since 1997. And so over the years, I don't know how many we have, maybe close to 500 people with Parkinson's disease, probably almost 1,000 healthy individuals with no dementia, no Parkinson, and probably close to that with Alzheimer's disease. So it's a huge repository of tissues. And so one of the things that we got charged with some years ago, this is the Michael J. Fox Foundation actually funded us to basically look at the staging of Parkinson's disease. So and see if we could look at the pathological staging and kind of see where does it start within the brain, and then how does it spread within the brain. So and so we did that, and what we learned is that one of the key areas where it starts is actually in the nose, in the olfactory bulb. So just above the nose is the olfactory bulb. So the sense of smell is actually one of the first symptoms that people have with Parkinson's disease. So and then there's two ways that Parkinson's can actually sort of spread, if you will. The pathology of Parkinson's can kind of spread within the brain. So it starts in the nose, but then it can go up from there to a place called the amygdala, and then up to the cortex. If that happens, we think that people get dementia with Lewy bodies. If it goes down into the brainstem, then we think it is more typical Parkinson's disease. So, and so if you see this pattern is just all the different areas of the brain. There's this little yellow blip. I'll see if my pointer, I don't know if I can get my pointer, I can't get it, but that little yellow bar, there's a little blip there. That's that amygdala area of the brain, and we think that's that sort of bypass track where it kind of converts to go up into the cortex of the brain and then become a dementia disorder, versus going back down into the brainstem and then going up through the brainstem being more of a Parkinson's disorder. So we start olfactory bulb, either brainstem, limbic area, and then potentially spreading to what's called neocortical, or within the cortex of the brain. So the other thing, so that was our staging system. So, and most people, I'm just going to go back here a second, but when most people with Parkinson's disease probably have actually had Parkinson's a really long time before they actually get the tremor or movement problems of Parkinson's. So, so these changes can actually just kind of sit in the brain, in the olfactory bulb, or maybe in the lower part of the brainstem, cause constipation, cause sleep disorders, cause reduced sense of smell, before those movement symptoms even start. So these studies really help to kind of showcase that sort of slow progression, maybe over 10 to 20 years before people actually get Parkinson's. So the other thing we were charged with, this is another paper that was funded basically by the Michael J. Fox Foundation. So they wanted us to find a place to biopsy to diagnose Parkinson's disease. So, so most of you know that it is the clinical symptoms of Parkinson's can be a little bit variable, especially when they first start. So, and so it can be really hard to diagnose, and I'll show you some papers on diagnostic accuracy in Parkinson's. So, so what we did, we actually started whole body donation. Oh, good. Oh, good. A little arrow. A little laser. Oh, perfect. I don't know if you can see the little laser spot there, but thank you. That helps. So yeah, so we started whole body donations. That was in about 2005. And the whole part of the purpose there was to really look, is there a place in the body that we can find Parkinson's? You know, rather than biopsy people's brains, can we look for it outside in the body? And so, so what we did is basically a staging system where we looked at every piece of tissue you can imagine. So we looked at skin, we looked at prostate, colon, all kinds of things, anything that we could potentially have access to as a clinician. We could potentially put a needle in it and biopsy it. So, and so one of the things, the first, I'm going to see if we can get our pointer here. These first, on this top right corner is a picture of kind of the highest concentrations of the different places outside of the brain. The first, I think, 3 or 4 are nervous tissue things. So the spinal cord, the sympathetic nervous system, the vagus nerve, and then the sciatic nerve. So nervous system tissues. So it turns out those are all pretty hard to biopsy. So we kind of quickly said, we're not going to even follow up on those. They're just too hard to get to. We're not going to biopsy people's spinal cords, for instance. So, but the next big peak is that blue peak right there, and then that's the gastrointestinal system. So, and what we learned, there's actually a top-down within the gastrointestinal system, sort of a top-down appearance of Parkinson's changes in the body. So, and the most common area actually is up in the salivary glands. So the submandibular gland, the parotid glands, these little glands underneath the tongue. So those salivary glands. And then as you move kind of through the gut, it becomes less and less prominent. So the kind of take-home point is, if the gut closest to the brain, that part of the brain is, that part of the gut is going to be the highest sort of concentration, if you will. So, and I'm going to talk about our approach to looking at the salivary glands, the submandibular glands. So interestingly, some of you, we're going to talk about, I think, skin biopsies for Parkinson's, because those are really coming along for diagnosis. But in our hands, we actually found that skin was not that helpful. So everywhere we looked at skin, it was very low percentage, and I can't remember which column there, but one of these way off to the right there, where there's very low percentage of skin. So we actually sort of threw out skin as a potential source for diagnosis, and really focused mostly on these submandibular glands. So another interesting thing, so accuracy of diagnosis of Parkinson's disease. So this was very humbling to us. So we think we're great clinicians. We watch our patients come in, we evaluate them, and we tell you, yep, I think you've got Parkinson's disease. Oh, I don't think it's Parkinson's disease. In early untreated Parkinson's disease, our diagnostic accuracy is only 26%. So when you start looking at people as they progress and start onto treatment, we get a little bit better with our diagnostic accuracy. But our best accuracy is actually when people are more than 5 years of diagnosis, and when they've had a long kind of response to medication, very predictable response to medication. So, so the highlight of this take-home point for this thing is we really need ways to better diagnose Parkinson's in its earlier stages. So
hey, Holly, this accuracy is that you just mentioned, is this among movement specialists or Parkinson specialists, or is this among general neurologists or primary care doctors?
Yep. So these are in our brain bank program. The people doing these assessments are movement disorder neurologists who are, quote unquote. Got it. All right. So yeah, movement disorder neurologists who are supposed to be experts at evaluating people for Parkinson's disease. So a little bit of caveat, it sounds like these are really bad statistics that maybe,
exactly.
Hey, yeah, exactly.
Very humbling.
26%. So, but remember, patients in this brain donation program are quite old. So they're, sometimes I'll go a day where everybody is over the age of 80, and sometimes in their 90s, and then a few people in their hundreds. And so sometimes it's hard to tell if that little tremor is that a Parkinson's tremor, or are they moving more slowly because they're just 95, or is that really Parkinson's disease? So,
and is the accuracy affected by the presence or absence of tremor? Like, for instance, a group of patients have the akinetic rigid type of Parkinson's, they have no tremor. Is it more difficult in your experience?
Absolutely.
Nail down the diagnosis,
and I think that's true in both in the clinic as well as in the brain bank program. So, reasons why people might move more slowly. So our diagnostic criteria is tremor, slowness of movement, and so people who move more slowly, it might be because they've got arthritis in the body, or they, have some orthopedic issue, a knee problem, or something like that that's causing them to move more slowly. So,
and then from the brain bank program, if the accuracy is 26% for untreated and 53% accuracy in those that respond to medicines, what are the most common mimics to Parkinson's that will make a movement specialist mistake them for Parkinson's disease?
Yeah, that's a good question. So, and some of this comes from our brain bank program. So when it looks like Parkinson's, but isn't Parkinson's, what is it? So sometimes it's things like Alzheimer's disease, so where we get thrown off, somebody who has some cognitive changes and they're just moving more slowly because of the cognitive changes. So we're going to talk a little bit about PSP, progressive supranuclear palsy. So that's about 10% of people with Parkinson's, that where we say this is Parkinson's disease, but it really isn't. Essential tremor sometimes we mistake for Parkinson's, so and so vice versa, both with and without. So, so some people will look like they have a tremor that's consistent with Parkinson's, and it really is more of an essential tremor.
So what about MSA in your series?
Yeah, multiple system atrophy is actually it's such a rare condition, so it's pretty rare that we would even see it in the brain bank program. I don't know. I think we have maybe 7 or 8 people in the whole brain bank program with MSA, so it's not a very common diagnosis. So,
did you see stroke as well?
Stroke, there, so you can get vascular Parkinsonism, if you will. So if you have multiple strokes in the brain, that can make you move more slowly and look like you have Parkinson's. So, yeah, this kind of humbling sort of take-home point, that our diagnostic accuracy is just not that great for some of these disorders. So it is getting better, though. We're talking about things like DAT scan. You folks probably are familiar with DAT scan, which assesses for dopamine deficiency. So we can use that. So if somebody has a funny tremor, is it a dopamine deficiency, which would be Parkinson's? So. And we're going to talk about spinal fluid assessments. We're going to talk a little bit about skin. We don't have as much data on skin in the brain bank program, but some of these other ways that we can get at diagnostic accuracy earlier in the course of the disease. So,
and have you ever encountered patients with drug-induced Parkinsonism that are very asymmetric and very similar to presentation to Parkinson's?
And what would they have? I'm sorry.
Drug-induced.
Oh, drug-induced.
And it's asymmetric.
Absolutely.
And look like Parkinson's disease.
So there's always a few. So there's a few weird drugs out there that really can make people look like they have Parkinson's disease. So anything that blocks dopamine for sure. But even drugs like amiodarone, which is a cardiovascular medication, valproic acid, Depakote, which is used for mood stabilization. So we have a few in our brain bank who were diagnosed with Parkinson's disease that were on Depakote. coat, so valproic acid, and have no signs of Parkinson's in the brain. So, but it was just the drug causing the symptoms. So, it definitely can't see it, and it can look exactly like Parkinson's, where the symptoms are so similar that you really can't tell the difference. So I think that's why we essentially need sort of better tests, if you will, besides just the doctor saying, this is what we think you have. So, alrighty. All right, so this is another. I mentioned PSP, or progressive supranuclear palsy. So this is what used to be thought of as a very rare variant of Parkinsonism. So, but what we found in the brain bank is it's actually about 10% of people. So first of all, 10% of people with PSP pathology within the whole brain bank program. So BBDP stands for Brain and Body Donation Program. So, and then they can have either dementia or they can have Parkinsonism. And then there's some people who have what we call incidental, which is that they have the pathology there, but they do not have either Parkinsonism or dementia. So we call that incidental PSP. So, and I know you've done some work on incidental PSP in the past. Dr. Affidente's worked on that in the past. So. And then if we look at people who got diagnosed with Parkinson's disease, almost 10% of them actually had PSP pathologies. So they were thought all through their life to have Parkinson's disease, and then at autopsy now are found to have basically a different disorder. So it has very much same clinical symptoms, but the pathology is very much different.
So are these patients that have been levodopa responsive, therefore all their lives are levodopa responsive?
Everything, and they fooled us too, because we as the people doing their assessments are saying, yep, this looks like typical Parkinson's disease. So,
and then I have some patients that come to me with brain MRI showing the so-called hummingbird sign,
right.
And then I don't see the full clinical picture of PSP. Their eye movements are good. Maybe they have some balance issues, but they're in their 70s or 80s. They're not pseudobulbar. They don't have dysphagia. So they don't have the classic signs of PSP yet, except for this hummingbird sign. But is this hummingbird sign something that we can put our hat on and say, yep, that's PSP?
I think it's just an MRI finding.
Exactly.
But
can you make a diagnosis therefore of PSP?
No. You would never make a diagnosis of PSP with just an MRI finding. So you really need the clinical symptoms that fit with the diagnosis.
So. And then did you look at those patients that were mistaken as PSP? Is there something that makes them kind of, on hindsight, tell you, yep, if this particular feature favored PSP, that looks like Parkinson's versus, yep, this is Parkinson's disease.
Yeah,
like the tremor, I don't know, balance issues.
And that's a good question. And we don't have a lot of that data in the brain bank program in terms of their clinical progression. Is there anything about them that, and I'll show you something on sense of smell here in a minute, but because that might be a distinguishing thing. So people with Parkinson's lose their sense of smell. People with PSP don't lose their sense of smell. So
wonderful. And then the so-called inability to look down. So this vertical gaze, supranuclear gaze palsy, they're not able to look down, right? That's a classic, textbook definition. One of the criteria we look for in differentiating PSP from Parkinson's disease. But is this something we see commonly in the beginning of PSP, or is this a later feature?
It's a very good point. So no, you do not usually see the eye movement symptoms early in the course of PSP. So it often takes years before that, and there's a decent chunk of people, probably almost half of people, who never get the eye movement changes. So
therefore, would the imbalance be the number one symptom that will make a doctor like you and me mistake this patient for PSP?
Yep.
Because we say balance is a imbalance is a relatively late feature in Parkinson's, right? Whereas in PSP, it's a very early feature. It tends to be early. So when they come to me and they say, I keep falling, that's my first symptom. I freeze, I fall, I'm not dizzy, I'm not fainting, I'm well hydrated. My balance is just awful, right?
Yeah. So early falls, early in the course of Parkinson's disease, should make you at least kind of think about whether this could be an alternate diagnosis like the PSP. So. Yeah, so common in so PSP common in kind of what we think is Parkinson's disease, and then if you look at dementia, so people who come into the program with more of a cognitive disorder or dementia disorder, so 60% of people with PSP who had a dementia presentation were completely not recognized, so they were called Alzheimer's disease or cognitive disorder, not otherwise specified or something, so they were not recognized as PSP.
And this is dementia without hallucinations.
Yes,
right?
correct. Yes, yes. So these are folks that have dementia. They don't have Parkinsonism, so but they just have dementia, and they have PSP pathologically. And this group we really don't understand at all. So I don't think we have good ways to sort of tease that out. And why is this important? So I guess why is this important? So I mean, we treat everybody the same, so if you have movement problems, slowness of movement, we're probably going to treat you with a Parkinson medication. If you have a tremor, we'll probably treat you with a tremor medication. If you have cognitive problems, we might treat you with a cognitive medication. So so it doesn't matter quite so much in the clinic right now. We're going to manage people's symptoms as best we can. So but where it will start to matter is when we get more specific treatments for people. So there is a big push to develop therapies to slow progression of Parkinson's and PSP and Alzheimer's disease. And with Parkinson's, we've got this alpha-synuclein protein, and so we're developing antibodies that help to clear out that protein to kind of clear it out, But if it turns out you really actually have PSP, which is a completely different pathology, then you're going to potentially be treated with the wrong medication. So
just for the benefit of the audience, so what disorders out there have alpha-synuclein in the tissues?
Yeah. So Parkinson's disease for sure. So dementia with Lewy bodies.
Right.
There's a REM sleep disorder. So people who have real vivid dreams and act out their dreams probably have alpha-synuclein. There's a rare disorder called pure autonomic failure. And then people with multiple system atrophy can also have alpha-synuclein, although it's a little bit of a different deposition. It's non-neuronal. It's actually in the glial cells of the brain. So it's still alpha-synuclein. It's just in a different part of the brain cells.
So in other words, if we use a test to detect alpha-synuclein either in the spinal fluid or in the salivary glands or in the skin biopsy, if we see alpha-synuclein, this rules out PSP, right?
Maybe. Because I'm going to show you, I'll show you some data. In fact, I think that's, I don't have, I think I have it somewhere. Oh yeah, I do have it. It's coming up. It's next. So, so we'll talk about this here first. So let me just remember this. So, oh, this is the submandibular gland. So this is the data. So we looked at autopsy tissues. We did this sort of looking at everywhere in the body to diagnose Parkinson's. And when we looked at the submandibular gland, 89%, so almost 90% of people with Parkinson's disease had abnormalities, had the alpha-synuclein in their submandibular gland. And so we're like, wow, that's great, because this is a kind of an easy place to biopsy. So we can put a needle in your carotids or these little submandibular glands underneath the jaw. So, and then if you look at dementia with Lewy bodies, it's about 70%. And then as you go down to kind of lower forms of Lewy body disorders, which is Alzheimer's disease with a little bit of sprinkling of Lewy bodies in there, and then what's called incidental Lewy bodies, it starts to drop off quite a bit. But for Parkinson's and dementia with Lewy bodies, it looks pretty promising. So
Holly, can you talk to us a little bit about the so-called incidental Lewy body?
Yeah.
Well, what is it?
Yeah, that's a good question. So incidental Lewy bodies is basically like it sounds. So these are people who lived to a ripe old age, and died without any dementia, without any Parkinsonism. So they were fairly neurologically pretty normal. So, but yet they actually have the pathology of Parkinson's disease in the brain. So, and it turns out that that's actually very common. So,
and how old are these individuals that have
so
incidental Lewy body in their tissues?
Yep. So these people are like 86 to 88 years old. so fairly older population.
So it could be one of us here, in other words, right?
So
we don't have
so
Parkinson's, we're just in that age group.
So yeah, if you're in that age group, statistically, you would have it's about a 25 to 30% chance of having Lewy bodies in the brain. So, and we've learned that through the brain bank. So,
and is that a risk if they live long enough? Therefore, they have no symptoms, right?
Yep.
If they had lived longer, would these patients with incidental Lewy body they have converted to Parkinson's down the road, or dementia with Lewy bodies?
Some studies by Erica Driver-Dunkley here, but the answer is maybe. So we even the people with incidental Lewy bodies, we have smell testing on those folks. So they're normal in the sense they don't have dementia. They're normal in the sense they don't have Parkinson's. But they might have a reduced sense of smells. So suggesting that they might already have the kind of the earliest symptom, if you will, of Parkinson's.
So obviously this is from brain tissue, right? But can we do, for instance, which is commercially available now, an alpha-synuclein test in the skin or the spinal fluid? If I'm in my 80s and I'm kind of walking a little slower, I have orthopedic issues, I'm not sure whether this is the beginning of Parkinson's or not. Do I have incidental Lewy body in my body or brain at this point?
Yeah.
Would you recommend, therefore, testing for alpha-synuclein for such patients?
It's tough because knowing that you have a third of chance, so you can be completely normal and have about a 30% chance of having this protein in the brain. So so is that helpful in somebody who's 85 years old? So if you were 60 and had this protein, I would be a lot more concerned about it. So, but if you're 85 and you have it, I'm like, I don't know, that could just be sort of normal aging to some degree. So
if we live long enough, all of us will get incidental Lewy bodies.
Yes, and Alzheimer's disease. So, and that's the other sort of take-home point.
Yeah, be careful what you ask for, huh? You ask for a long life.
You will get all of these pathologies. So that's just kind of the fringe benefit of being on this earth a long time.
Do we know what the risk factors are for this so-called incidental? It's in my body. I don't even know it's there. It's a bad protein. Are there risk factors in the environment that they've identified that lead to this bad proteins?
Yeah, so right, and we're not specifically studying that in a brain bank. It's kind of hard to do that because people are from all over, and so it's not a way to really study like the risk factors.
It might be a good idea to do that because now they're talking about just pollution, the small particulate, substances you breathe in the air, like smoke, pollution, and they know for a fact that these are now risk factors for many neurodegenerative disorders like Parkinson's, dementia with Lewy bodies, Lou Gehrig's disease, Alzheimer's disease. So it might be interesting to find out in those patients of yours with incidental Lewy body, okay, how many live in let's say urban communities, metropolitan cities versus very rural areas where the level of pollution is much lower. Yeah, it's something I think interesting to look at.
Yeah, it is interesting. So and we have a group of scientists that are studying the impact of air pollution and risk for Parkinson's disease.
There's a question from the audience. The lady in the green shirt.
Yeah, hereditary. So the question is it hereditary? So
you mean the incidental Lewy body, right?
Yeah, yeah, I mean, just Parkinson's in general, about 1 in 10 people will carry a gene that increases their risk of developing Parkinson's. So for a number of people, the genes could be more of a determinant than any sort of environmental.
And we can now test for those genes in a very, cheap manner nowadays, right? There's like a gene panel from VTech.
Yeah, there's a thing called PD generation, which is a research study that allows for free genetic testing for people with Parkinson's disease. So if people are always interested in knowing whether they have a gene.
So what percent of patients with Parkinson's with no family history, we just do a gene panel, what percent of them will carry one of these genes?
With Parkinson's? Right. Yeah, it's about 1 in 10.
Wow.
Yeah. So it's more common than we thought, that used to be thought that it's, less than 1% kind of thing that had a gene for Parkinson's.
And that's only for the genes we know of, right?
And those are the genes we know.
There's a lot more genes to be discovered.
So right, and that PD generation study has just recently switched to doing not just targeted genes, but actually doing whole exome sequencing. So they're going to do actually whole genome sequencing. Sorry, we were already doing the targeted genes with the whole exome. So now doing whole genome, looking for novel genes that may increase people's risks. So
and then in the future, when we find ways, like for instance, for Parkinson's, right, we diagnose it with with what we call prodromal Parkinson's. You don't have the symptoms, the motor symptoms yet. You have the REM behavior disorder. You have the constipations, the loss of sense of smell, and so on and so forth, the so-called non-motor or pre-motor stage of Parkinson's. And then we talk about, taking out the alpha-synuclein from their tissues, right?
Yep.
We're working on that. Yep. But do you foresee that we may also do this for patients with incidental Lewy? In other words, even move the needle even earlier. Yep. Why wait for the non-motor symptoms? Let's even go, preclinical.
Yeah, and I have a little bit of data on that too. That our detection methods actually require a certain burden of alpha-synuclein. So it may be that even those people with incidental aren't positive enough. I mean, in fact, like in the submandibular gland, it's only 11%. So even though the pathology's in the brain, we're not detecting it when we biopsy tissue. So, and I'll show you some spinal fluid analysis here too. So,
okay.
Before we leave submandibular gland, so it kind of looked pretty promising, and we've been kind of pushing it for a while now. Although we're starting to see skin as being a better, first of all, an easier way to biopsy. So we can just do a little simple punch biopsy of the skin. Whereas the submandibular gland, it actually requires an ear, nose, and throat surgeon to go in and do a biopsy, whereas a skin punch biopsy is pretty easy, for us to do just a little pencil size, not even eraser size, punch a skin and send it to the lab. So that's winning. And then spinal fluid is also looking very accurate. It's a little bit more invasive, but it's very, very accurate from a diagnostic standpoint. So,
and are they working on blood as a
yes, so blood is been a little discouraging. Yeah. So Alzheimer's is a little ahead of the game, where they actually are starting to get blood testing for Alzheimer's disease. It looks to be pretty accurate. So Parkinson's is a little bit behind. What we thought was a good test, and I forget who, somewhere in the Midwest was doing a big study on trying to do blood testing for it, and unfortunately still kind of a little bit not solid enough for us to actually start to utilize it.
And then this year is so exciting for Alzheimer's. They have their amyloid PET scan, which really takes a picture of the brain and sees this protein called amyloid, which is the bad protein that deposits in the brains of Alzheimer's patients. So if in Parkinson's, it's alpha-synuclein, right? So is there an alpha-synuclein scan that's being developed?
So it's being developed. It's just not commercially available. So amyloid is a lot easier to image. So it's basically bigger clumps of it. So it's a little bit easier to have something tag it and show up on an imaging study. So, doing like a PET scan, for instance. So whereas with Parkinson's, these nuclei that we're talking about are really baby tiny nuclei. And so even if they're loaded with alpha-synuclein, it may be very hard to pick them up on a scan. So that's been the problem of trying to develop imaging testing. So it'd be great if you could just put somebody in a scanner and say, yep, you've got Parkinson's, and this is what stage you are at. So,
wow.
Question?
I have a question.
Does the U.S. military check for a nose man? Not that I'm aware of. So, not that I'm aware of. They probably do, right? So,
well, they check for vision and hearing. I'm not sure about color blindness. Oh, I think they do for pilots and all that.
Mm-hmm. Yep. All right. I think that sounds like.
Yep. Which begs the question, though: do all patients with Parkinson's, do they all lose their sense of smell?
Yeah. Right. So I have some data on that too. I'll show you here in a flash. So, and the answer is, it's mostly yes. So, but not quite 100%. So,
and then you talk about in your staging that you did. You started with the olfactory bulb, so brain first, right?
Right.
But many are talking about the gut first, right? It starts in the gut, whereas you talked about the pathology.
Hold that thought, because we got a slide on that too.
I want many slides ahead of you then.
I'm here to answer every question that we have. So, yeah.
Right.
Yeah. I mean,
Yeah.
your point. So the point of how easy it is to
Yeah,
just check
you'd rather do a
somebody's
smell test, right, rather than a
check
spinal
somebody's
tap.
sense
Correct.
of smell. So the problem is there are a lot of reasons why people lose their sense of smell, and
Right.
most of them are not Parkinson's disease,
Including COVID.
COVID,
No.
head injury, sinus surgeries, long histories of allergies, things like that. Smokers, active smokers. So, yeah. Yep. So there's a lot of reasons. So, people don't have to panic if they think they've lost their sense of smell.
Mhm.
So we know it's associated with risk for Parkinson's,
Yeah.
but most people don't develop Parkinson's.
Question there in the corner.
Yeah.
Let me get this mic to you so the people on Zoom can hear you too.
Yeah.
Yeah, here you go.
Say 10% have the 10% have the gene to have Parkinson's. Does that show up actually in society? Say in the US, do 10% of people in the US, are they diagnosed with Parkinson's or not?
Yes. So that is that 10% for genes for Parkinson's comes out of mostly US based data. So people living with Parkinson's mostly in the US, and 10% of them carry a gene.
But FYI, just for your information, there was a recent Italian study which showed that if you do you examine the first, second, and generation of patients with Parkinson's, about 20% of patients with Parkinson's have a family history of it, which tells me if it's 20%, then there's a lot of genes we haven't discovered yet.
Yeah. All right, and then here's just, this is just a thing on incidental Lewy bodies and sense of smell. So incidental Lewy bodies means, remember you have the pathology of Parkinson's in the brain, but you don't have any symptoms of Parkinson's or you don't have any dementia. So, but it turns out, so people with Parkinson's have a really fairly dramatic reduced sense of smell. So this University of Pennsylvania smell identification test. You scratch and sniff and you have to identify a bunch of senses. A bunch of smells and report it. So Parkinson's does very poorly. People who are controlled, so just kind of older folks, do better, and then people with the incidental Lewy bodies are kind of somewhere in between. So there are a lot of people that have reduced sense of smell with incidental Lewy bodies.
Okay,
so,
quick question then, based just on that slide. So does that tell me then that the more Lewy bodies I have or more alpha-synuclein I have in my tissues, the higher the chances that my sense of smell will go down?
Absolutely. So it is correlated with like the level of pathology, and we've definitely learned that in our brain programs. So this test, by the way, is a score out of 40. So you can see people with Parkinson's are fairly low. So 10, if you have a score of 10, that's just random chance. So you have a 1 out of 4, it's picking 1 out of 4 smells. And so you would have a 25% chance of getting it right, even if you were just guessing. So a score of 10 would be just random chance. So people with Parkinson's are pretty close to just random chance on their sense of smells. So.
And do they all know that they have lost their sense of smell?
Yeah, and I'll show you that. I've got that coming up here too. Boy, you're like
I know.
helping me with my talk here. So I want to just talk too quickly before we leave this is the counterpoint of this. If you have a normal sense of smell by this testing, you're very unlikely to have Parkinson's changes in the brain. So it is very, very much a normal sense of smell is very much associated with lack of these pathologies. So this is the awareness of hyposmia. So because I was interested, this is actually a study I wrote up. I was very interested rather than have everybody do scratch and sniff, can you just ask people, how's your sense of smell? And I was interested if people with Parkinson's were aware of it. So most people with Parkinson's are aware they've lost their sense of smell or have a reduced sense of smell, but 16% were unaware. So there's a proportion of people who say, yep, my sense of smell is great. And then 47% of those without Parkinson's, so these are just our sort of elderly control population, 47% were unaware that they'd lost their sense of smell. So what was interesting on this is that if you were, if you've lost your sense of smell, but you thought your sense of smell was okay, you were more likely to have cognitive problems. And so the way I interpret that is you lose the memory of the smells. So it's not your sniffer, your nose is fine, but your memory of the smells is abnormal. So if you're worried if you're developing Alzheimer's disease, go get a scratch and sniff test and see how you score. And if you think your sense of smell is great and you score poorly, that may be a little bit of a concern. So, yeah. Would the spouse agree? So,
Meaning the loss of sense of smell.
mm-hmm. Yep.
Yeah.
Yep. Yeah, and that's a way to kind of get at it. So it's just to ask the partner, hey, how's their sense of smell? So because the partner, you guys are all smelling, if you live in the same household, you're smelling the same things. And if you smell the coffee percolating, but your partner with Parkinson's doesn't, then it's, so even if they think if it's, yeah,
Absolutely.
yeah, sometimes that's true. So
Absolutely. I was going to say that in my practice, it's usually the spouse that tells me first that the patient has lost his or her sense of smell.
This is just a quick one, but I wanted to include it. So this is the one fringe benefit of having Parkinson's. You have a lower risk of having cardiovascular disease. So, so cerebrovascular, lower carotid disease, lower risk of being on blood thinners, less abnormal heart rate. So, and it suggests that having Parkinson's actually helps to protect against vascular disease. So, and the thought is it actually is related to the sympathetic nervous system. So with Parkinson's, you're low on dopamine. And that's kind of what dopamine, epinephrine, norepinephrine all drive blood pressure and might drive cardiovascular health. So, one fringe benefit of Parkinson's.
You think that also has to do with them losing weight?
It could be.
Because if you lose your sense of smell, your appetite goes down, right? Then then to boot, you develop some difficulty swallowing. So between the loss of appetite and loss of sense of smell and difficulty swallowing, won't they lose weight and therefore their vascular risk factors are reduced?
All right. Another question? Yep. Yeah.
Can you repeat the question?
Yeah. Yeah. So, right. So if you talk about from the time of clinical diagnosis of Parkinson's, so the questions about life expectancy with Parkinson's. So clinical diagnosis, so the tremors, the movement problems, we think of relatively normal life expectancy. So if your average age of diagnosis is about 60, you're probably going to live to about 75, 78, 80, somewhere in that range with Parkinson's. So 15 to 20 year time frame from time of diagnosis. However, if you go back to like those prodromal things like the reduced sense of smell and the constipation and the sleep disorders, that could be 20 years prior. So the full course of Parkinson's can be nearly 40 years. If you think about the whole, that can be almost somebody's, later half of their lifespan. So it's very interesting.
There's a phenotype of Parkinson's that progresses more rapidly,
Absolutely.
Right? The rapidly progressive Parkinson's phenotype. So that probably will be shorter, right, in terms of lifespan.
All
Probably.
right. Yes, probably. So it can lessen the lifespan. So it doesn't have to, but it can. So, but most people on average actually live a fairly normal lifespan. So
yeah. Parkinson's patients either progress very slowly, and then they have the medium, moderate progression, and then there's a rapidly progressive kind of Parkinson's. You have one of the benign ones, usually the tremor predominant ones, right? They tend to progress a little bit more slowly. They have less of the slowness, less of the bradykinesia, less of the postural instability or falls, and therefore they tend to live a little longer. The so-called benign variants of Parkinson's.
all right, I'm going to quickly go through this one. So the point of this slide was just the faster rate of cognitive decline in people with Alzheimer's disease if they also had Parkinson's pathology. So the two pathologies together can actually be synergistic and make people progress more rapidly. So, and right now we don't have great ways of picking that up. So we just know it at autopsy and that they have both pathologies. But
although we do have patients with both Parkinson's disease and
Alzheimer's. Yep.
And Alzheimer's.
Mm-hmm.
How do we know? Because now we have amyloid PET scans. So some of my patients that I thought you're demented because of your Parkinson's. Guess what? I do an amyloid PET scan, and voila, I see amyloid all over. And at the end of the day, I kind of think, oh, maybe this patient has Parkinson's plus Alzheimer's. So that is possible, right?
Yep. Yes, yeah. So about half of people, if you have Parkinson's with dementia, about half of those will be due to the Parkinson's, and the other half will be due to Alzheimer's disease, so that you can actually have both.
So how do you differentiate Alzheimer's with Parkinson's versus dementia with Lewy bodies, which is supposed to be, features of Parkinson's and Alzheimer's altogether?
And there are some clinical, subtle clinical things that can help sort it out. Like a neuropsychologist can sometimes really help to sort of sort that out, whether somebody has just purely Parkinson's, dementia with Lewy bodies, or whether they have both, like a Parkinsonism plus a dementia, like an Alzheimer's disease. So this is the spinal fluid analysis in our brain bank program. So this is what we call RT-QuIC, which is a way to amplify that alpha-synuclein protein in fluids. So we can measure this in spinal fluid. So it turns out it's extremely accurate in spinal fluid for Parkinson's disease. So if you have PD, if you have Parkinson's disease with dementia, if you have dementia with Lewy bodies, it's basically 100% of people will have positive spinal fluid. So, and so this is why we think this is a very accurate test. So,
however, there are false positives.
Yeah,
for those,
there
right?
can be false positives. So, and then the accuracy starts to drop as we get earlier and earlier stages. So, so if you have Alzheimer's with just a touch of Parkinson's pathology in there, it's only about 60%, 57%. So if you have incidental Lewy body disease where you just have a touch of Parkinson's in the brain, then we're not as good at picking it up in the spinal fluid. So if you have it in the cortex and the kind of thinking, the cognitive area, it's very, very accurate, but it's not as great in the kind of lower part of the brainstem. So, so I worry a little bit. This is my another kind of take-home point. I worry a little bit about these, like the skin biopsy testing and the spinal fluid testing, these tests that we're now sort of using commercially. Both skin biopsy and spinal fluid analysis are commercially available for diagnosis. But if we start pushing it earlier and earlier in the course with people with milder and milder symptoms, we may not be as accurate versus these people with well-established disease where it's much more accurate. So,
Because of the possibility of false positives, right?
Yeah.
Now, is this alpha-synuclein RT-QuIC in the spinal fluid? Is that available here?
Yeah. Yep. You can. There's the big lab that does it is a lab called Amprion. So, but yeah, it's available. We've been using it with the PPMI study, the Parkinson's Progression Markers Initiative study, for years. So, and it is commercially available test. So, I'm seeing. This is for the alpha-synuclein in the spinal fluid. So it's a commercially available.
I have some patients that really act like they do have Parkinson's or levodopa response. I'm not sure whether they're one of those PSP patients that you just mentioned, or probably MSA that's mistaken for Parkinson's. Anyway, I do a skin biopsy, it's negative.
Yep.
And I kind of say, maybe we should look at their spinal fluid.
Yeah.
What do you think of that thought?
Yeah, I think so. So I feel like this spinal fluid is going to be more accurate than the skin testing. So
More sensitive.
Sensitive, maybe not more accurate, but more sensitive. So this gets at the body first. So people, you probably all hear about Parkinson's starts in the gut. You may have heard that. So we're able to look at that in the brain donor program because we have brains on people, but we also have whole body donation. And so we can look at people and say, okay, if it's in the brain, do we also see it in the gut? And the answer is yes, you can see it in the gut. But we never see it the other way around. We never see it in the gut first before it gets to the brain. So in people, if you have it in your gut, you probably also have it in your brain. So
were you looking only at the stomach, or even
this was the stomach and the
intestines?
vagus nerve, so the upper part of the gastrointestinal tract. So
That doesn't rule out the possibility
That
of
could-
alpha-synuclein more distal to the stomach.
yeah, although
right?
remember, we talked about this sort of what they call rostral caudal. It's so you get greater concentration of that alpha-synuclein protein up further north in the brain. So. And so if it starts in the gut, it moves through the gut very quickly. And so you could think about it like seeding, something getting in through the gut and then quickly moving up into the brain. But it doesn't seem to sit in the gut for long periods of time. Otherwise, we would be picking it up in the brain donor program. So So that's kind of an interesting thing. So this is another kind of cool study I just thought I'd throw out there. This was what we call conjugal synucleinopathy. So we were interested to see, so we have lots of husband-wife teams, partners where they live together for many, many years. And the idea is if you live together, which is called conjugal, if you're living together, if you live together, are you more likely to get Parkinson's if your partner has Parkinson's? So we looked at that in the brain donor program, and basically we didn't find it. So, and so that would argue that at least Parkinson's doesn't seem to be contagious. So, because that's been a question too, if you're sort of exposed to somebody, could it actually be contagious? So,
won't you think that 16 out of 90 would be a significant number?
It sounds
that's
like
20-something%.
Yeah, it sounds like it. But remember that incidental Lewy bodies is about 25-30% of people. So, if it were really like a strong association, you would start to see higher and higher rates rather than actually, lower rates of Parkinson's. So.
So do you think this slightly higher incidence is because they grew up in the same area, they were childhood sweethearts?
Yep. Yeah, so of course if you're exposed to something that might increase somebody's risk for Parkinson's, then the person, if you've known each other since high school, you may have been exposed to some of the same pollutants and things like that.
And all that, right? Or same well water.
All right.
Or polluted water.
I'm going to switch gears. We've got a few more minutes left, and I just want to touch on a few things that are kind of not Parkinson's. So this is COVID. So this was really one of the first things when COVID came out, first when the pandemic started, was does it affect the brain? And we were seeing lots of strokes in people with COVID. So, and this was very early on. And so we actually had an autopsy program for people who died from COVID. So the brain bank program is actually right next to Boswell Hospital out there. And so the people ended up dying from COVID, and they would donate their bodies to science. So, and we saw a lot of evidence that COVID had an effect on the brain. So some people got encephalitis, some people had strokes as a result of COVID, and 20% of them had brain invasion from the COVID virus itself. So I remember seeing this, and I had a huge panic attack that we're all going to be getting some terrible neurodegenerative diseases. But then I took a step back, took a deep breath, and I realized a lot of viruses actually get into the brain. So even influenza gets into the brain a little bit. So, but for sure, viruses like herpes virus and shingles virus and West Nile virus, there's a lot of viruses that have some brain penetration. So, and we actually think what we've learned now with COVID is it's not the virus itself, it's all the inflammatory process that happens with COVID that causes the brain effects rather than the virus itself.
So has anyone
cool? But
has anyone looked at whether there's increased Lewy body in the brains of patients that suffered COVID?
Yeah, so we're continuing to study that. So because people originally said, "Oh wow, COVID affects your sense of smell," and so maybe that makes you at higher risk for getting Parkinson's disease, and especially if it gets into the brain. So.
I'm not sure, but about your practice, but I've seen an increase, an uptick in number of patients with Parkinson's since COVID.
Yeah.
Am I imagining that, or
we don't know yet? I don't think so. All right.
I mean, I've seen worsening of Parkinson's after COVID, right? That's not an uncommon issue, but de novo, diagnosis of Parkinson's seems to be on an uptick since COVID. I think many epidemiologists have shown that. Yes.
Yeah, correlation between Parkinson's and the COVID vaccine, and I'm not aware of any risk associated with that. So, part of the problem is so many people were immunized against COVID originally that it's kind of hard to do a study. Hard to find a cohort of people who weren't immunized. So, but you could start to look at it, in nations where they didn't have big access to the vaccines. So.
Actually, there's some data on that already, and they found out that those that were vaccinated had less frequency of de novo Parkinson's down the road in comparison to those that were not vaccinated.
So potentially suggesting there's a protective effect, that reducing that sort of inflammation effect of the...
Well, reduction in chances of developing COVID and therefore less chances of inflammation in the brain. So inflammation is part and parcel of that alpha-synuclein misfolding and, clumping and forming this Lewy body. So the inflammation is part of that equation as to why this alpha-synuclein aggregates in Parkinson's disease.
All right, I got a couple more slides here. I promised I would talk about essential tremor, so I just want to quickly touch on essential tremor. So this is not Parkinson's disease, nothing to do with COVID. So, but we've been looking at essential tremor for a long time, and basically, net upshot is that we have not found that essential tremor is linked to neurodegeneration. So, so this was a study. We looked at the cerebellum in the brain, which is kind of where we get our motor control. And we didn't find that essential tremor had a loss of these cerebellar Purkinje cells. We also looked at risk for incidental Lewy bodies in people with essential tremor. We looked at incidental PSP pathology, and we looked at incidental Alzheimer's disease pathology. And we didn't find any increased risk in people with essential tremors. So as best I can tell you today is that essential tremor is mostly a tremor, but doesn't seem to be linked to any of these sort of neurodegenerative things. So this is a study just looking at development of dementia with essential tremors. So, and actually the black curve, the lower curve, is the risk of dementia in people with essential tremor. It's actually lower than the general population in our studies. So, so I feel like that's pretty encouraging to people living with essential tremor. That doesn't seem to be linked to these other disorders. So, and I think that is it for my slides.
And yet we see some patients with what they label as ET plus, right? Essential tremor plus. In other words, they have essential tremor and they develop Parkinsonian features or cerebellar features or dementia. So are these just two diseases at random?
Yeah, I think so. At least, as best we can tell, it does seem to be just disorder. All of these things are disorders of aging, right? So essential tremor increases as you get older, Parkinson's increases as we get older, Alzheimer's disease. And so statistically, you're just once in a while going to see both in the same person. So, it's interesting.
And then we have many patients with chronic, long-standing decades of essential tremor, and then down the road, they've had essential tremor since they were little kids or young adults, and now they're in their 60s and 70s, they develop Parkinson's. And my sense is that some of these ET patients, or should I say a good chunk of these ET patients, if they live long enough, may develop Parkinsonism, and a good chunk of them would develop Parkinson's disease. So would long-standing chronic essential tremor be a risk factor for Parkinson's?
And so yes, you absolutely can see that. But as far as we can tell, at least with the brain bank, that it doesn't seem to increase people's risks. So
yes.
So does dopamine in the gut affect our automatic motor system or subconscious motor system?
Yeah, so does dopamine in the gut affect our movement system? So boy, I don't know that I know the answer to that. So
neither do I.
Yeah. So there are people that are looking at treatments that are that work primarily in the gut, with the idea that they're actually going to get transmitted into the brain. So through the vagus nerve in the gut. So and so I think there's some thought that at least that can happen, that there's a connection there so we think of the brain controlling the gut, but not the gut controlling the brain. So, but there seems to be at least some evidence that there is this sort of back and forth communication. So,
I remember some studies that said that if you have a leaky gut, though, there's a higher frequency of this, neurodegenerative disorders, including Parkinson's and Alzheimer's.
Yeah.
But as to whether there's a direct correlation between the dopamine levels in the gut and then, the motor symptoms or the cognitive function of the patient, I'm not sure there's a study that really ties that up.
What's your gut feeling about it? So we think about, this is how I think about this whole concept of at least Parkinson's disease and probably neurodegeneration in general. So that it's coming from somewhere, it's not just our brain is sort of doing this to us because it's mean and nasty to us. So it may be partly genetics, which is just your biology, but probably more importantly, it's our body interacting with our environment. So, and I think what we see is that we're not, when 100 years ago, we were living till we were age 50. And so our bodies just aren't keeping up with aging. So they become vulnerable to food that we're eating, environmental toxins. They just don't have the wherewithal or the capability to continue to sort of fight it off. So that will probably get better as we learn about successful aging. So I think people our bodies will figure out how to get around these diseases. So. Yeah. Right. Yeah. Right. So alpha-synuclein is in our bodies. There's a normal form of alpha-synuclein in our bodies. So what's the abnormal part in Parkinson's is that it starts aggregating. It starts to clump together, and that's what we see in the brain under the microscope. So something that we are interacting with in our environment is triggering that conversion from normal protein to abnormal protein. So, and that's the same in PSP. That's the same in Alzheimer's disease. All of these disorders have this problem of a normal protein converting into an abnormal protein.
So do you foresee in the future that the therapies will be directed towards preventing clumping and aggregating of the so-called normal alpha-synuclein in our body?
Yep, and that's already happening. It's for Parkinson's, it's still under research. For Alzheimer's, you can go get treatment for Alzheimer's disease with an anti-amyloid clumping protein.
Yeah, but I'm talking about prevention though.
Prevention, yeah. So I think that's probably in the future. So
I mean, we know we have the genes. You have the genes. That's probably
and
a
what it'll
setup,
take
right?
is first of all, genetic testing potentially in people,
Right.
but probably a very simple test, like a simple blood test that's can screen people. And if you're screen positive, we start to consider whether we put you on kind of preventative treatment. So
In other words, if you have a gene that predisposes to Parkinson, so far we have what you said, 11 to 15%, right? Although the Italian study said up to 20% we have a family history of Parkinson's. So if you have the gene and now you're getting elderly, probably in the future have a blood test. Yep, you've got this bad alpha-synuclein in your blood already. Maybe intervene in the future at that point.
Yeah, and I think that's kind of where things are headed. So
and this is where your pathology, brain brain is so exciting, right? Yeah.
Yep. Yeah. How do you? Yep. Yeah. So I'll just repeat the question, which is just that finding people, kind of that at-risk people, so the reduced sense of smell, and that we're doing mass screening across the country, actually across the world, for people with reduced sense of smell, and then screening them for that abnormal protein in the spinal fluid now. So.
Well, wouldn't your conjugal data that you mentioned earlier suggest it's probably not so much environmental?
Yeah, right. So yeah, you're right. The conjugal data would suggest that it's maybe not so much environmental. So, yeah, we were thinking about it as more of a, right. Yeah, if you've known that same person for, since you were 20 years old and now you're 80 years old, you've probably had the same types of exposures. So, so yeah, that would kind of argue against it. So, although I actually think that if you, I think it's more of it's a gene environment interaction. So there's like some genetic predisposition, and then the environment then comes and sort of pulls the trigger, if you will. So, so some people are purely genetic, but then I think probably the most of us have sort of genetic risk factors and then combined with the environment. And so then the well spouse, if you will, maybe doesn't have that gene that sort of just kind of gives them a little heightened risk for developing Parkinson's. So.
There's a question here. Does a positive skin biopsy for alpha-synuclein mean you have a neurodegenerative disease?
Yeah, that's a good question. So does a positive skin biopsy? So we actually don't know that. So
or positive anything.
We know that if you have Parkinson's, and we test you with a skin biopsy, you will probably test positive. So what we don't know is if you don't have Parkinson's, and so they did they did controls, and there was, I think, 5% of controls had positive alpha-synuclein. So these were people without any neurologic symptoms, as best they could tell. So about 5%. The average age was 60. So, but what happens when you're 70 or 80, where you're more likely to have some of these abnormal proteins? And what do you do with folks? You get a positive test, and do you tell them that I think you're going to get Parkinson's? I don't think we know that yet. So,
Is there any link between that you know of, link between diabetes and Parkinson's?
Diet and Parkinson's. So-
Diabetes.
Oh, diabetes. So, I don't know about risk factor. I know there's some studies that say if you have both Parkinson's and diabetes, that you might have a more kind of aggressive course, if you will.
Yeah,
So,
I think more dementia, more because of the more vascular risk factors, more neuropathy, therefore more balance issues and falls.
although interestingly, you've probably seen some of these GLP-1 drugs, you know, the Ozempic-like drugs. Some of them are showing that they might slow progression in Parkinson's disease. So it's interesting.
Now they're also talking about a different class of drugs, the glioflizones. These are the Jardians and there's one more class of drugs for diabetes. They're talking about it being protective against dementia in Parkinson's.
All right. Oh, yeah. We could go on all night here. Let me know when we need to.
We got 10 more minutes.
10 more minutes. Okay, good.
I have a question, doctor. I read an article in New York Magazine about people with Parkinson's have a certain type of odor.
Mhm.
And have you seen that firsthand?
Yeah, it was an interesting study. I think that was in the UK somewhere where Scotland, where I can't remember, the wife this woman was able to sniff the clothes of people and correctly identify who had Parkinson's and who did not. So, yeah. And does that reflect that maybe there's a different microbiome in the people with Parkinson's, which is probably true, that there is a different microbiome, and that produces a different odor that some people can't detect apparently. Yeah. Musty smell that you got. I don't know if you heard that. Yeah. As a test, yeah. Yeah, she apparently was pretty accurate at detecting Parkinson's. So, yeah, go ahead.
After a person has Parkinson's and you know it as a physician, what drugs do you identify to give to that patient, and how does that drug attack Parkinson's?
Yeah. So that almost is another hour-long discussion, is the management of Parkinson's disease clinically.
Give the Reader's Digest version, please.
But just kind of the long and short version. So the motor symptoms, the physical symptoms of Parkinson's are due to dopamine deficiency. So the tremors, the movement problems. So most of our treatment is geared toward replacing dopamine in some fashion, which is usually a medication called Sinemet or carbidopa-levodopa therapy. So, and then variants of that. So, and then of course all the non-motor symptoms too that we might be addressing. So, yes, dopamine goes down in Parkinson's patients, and we replace their dopamine, which helps them move better. So, we don't think dopamine does anything to alter the progression, though. So it really is just replacing that missing chemical. All right.
Hey, thank you, Dr. Shill.
All right.
We're going to move on to some questions. If anyone has any more questions, please raise your hand. Yeah, okay, let me come to you.
Are there any questions from the Zoom audience?
Is it more prevalent in males?
Yeah, Parkinson's is more prevalent in males, absolutely. It's about 65% male.
Okay. One question from Zoom. I have PD, had a DAT scan, had RSBD about 20 years before diagnosed in 2018. Other internal symptoms a number of years before diagnosed contribute to other things. I've lost my sense of smell. I have essential tremors, movement tremors, and not resting tremors. I have other movement symptoms as well. Now mild cognitive decline. Is diagnosed correct if no loss of sense of smell?
Right. So yeah, it's a good question. So I mean, certainly all that prodromal with the REM sleep disorder really sounds suspicious for Parkinson's. A positive DAT scan suggests positive for Parkinson's. So
Although
yeah,
if you have the non-motor symptoms and your DAT scan is positive, does that mean you have Parkinson's at this point?
Yeah, right. So we know too that your DAT scan can convert before the patient converts. So
Got it.
so sometimes it can be a sort of a prodromal thing.
So you really need to have the motor symptoms
Yeah.
with an abnormal DAT scan to say,
Yep.
yep, you've got Parkinson's
Parkinson's
disease.
is still a clinical diagnosis.
Right.
It's still watching the patient, how they move and how their neurological exam before we make a diagnosis. So even though we have these sort of biomarkers that we can use, and we still rely on our clinical diagnosis.
Yes, go ahead.
Were there any brains with the DBS placement? And if so, were there any different findings between those patients versus patients without the DBS placement?
I'm sorry, I didn't quite.
Yeah, so were there any of the brains with DBS placement? And was there any difference between those brains versus?
Oh, right,
Oh,
yeah.
DBS
so
in the brain
DBS,
bank.
yeah,
What
yeah.
did you find?
Right, so
Did
right.
everyone have Parkinson's?
Yeah, yeah, I think most people did. So we did 2 analyses of DBS in the brain. So first of all, the DBS doesn't appear to harm the brain. So that's the first thing. So you put the wires in, and if you pull them out, you can't even tell that there was anything done. There's no pathway, there's no scarring, that sort of thing. Some people get some minor reactions to the DBS leads, but not prominent. So, and then the other sort of interesting thing, there was some thought that potentially DBS had some sort of protective effects. So, and the reason I say that is because some of the patients with DBS actually had a higher burden of disease than they would have been expected. So in a sense, they live longer with higher burdens of disease. So which I kind of interpret as, hey, the DBS actually helped them to live longer, essentially. So
In your ET patients, if there was no loss of the cerebellar Purkinje cell, which is what we were taught was the pathology in essential tremor, that's why they developed the so-called cerebellar signs when they have long-standing ET. So where is the pathology there?
yeah, where's the pathology in
Right.
essential tremor? So I don't think we know.
Huh.
Right now, it's a circuit. It's an abnormal circuit that gets overactive, but we can't find like the spot where it starts for essential tremors. So there's not one spot.
So really, for patients, what we diagnose as ET, then for all their lives, and then develop Parkinson's down the road, you do a pathology study. All you're gonna be diagnosing is Parkinson's, then, right? You're gonna say, yeah, brain tissue showed ET plus PD.
Yeah, with essential tremor, typically we just find the kind of usual age-related changes. So
Interesting.
Hey, we got one more question from the Zoom audience. Any relationship seen between pancreatic cancer and Parkinsonism?
not that I'm aware of. That was an easy one.
Yeah.
The
Anyone
only,
else?
the only cancers that you should be concerned about if you have Parkinson's are the skin cancers. Okay.
Yeah.
Not just melanoma, but there's also an increased frequency of squamous cell and basal cell, which are dime a dozen.
Yeah.
Among non-Parkinson's, aging patients.
Yeah, melanoma in particular, there may be genes that kind of increase people's risk of both melanoma and Parkinson's disease. So, because you can see family members that have Parkinson's in one member and then melanoma in another family member. And so there's thought to be some potentially genetic contributors to both those things. So,
And it's both ways. If you have Parkinson's, you're more prone to melanoma. If you have melanoma, you're more prone to Parkinson's as well. Okay.
yeah, and it's low. So the risk. So if you have a melanoma, like what's your risk of getting Parkinson's? It's very low still. I mean, it's not. It bumps it a tiny bit, but not dramatically. So, all right.
More questions?
Good.
No,
Well,
thank you,
for-
Dr. Shill.
All right, we're done. So thank you.
Yes. All right, I would like to acknowledge and thank our exhibitors for their role in the program. Abbott, Acadia, Amneal, Boston Scientific, Medtronic, Supernus, MERTS, and ASU Speech. Now we're going to move on to the raffle.